Hi, everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today, we will be speaking with Maria Inês Schmidt, endocrinologist and epidemiologist, professor at the School of Medicine of the Federal University of Rio Grande do Sul, Brazil. At the end of the podcast, learners should be able to understand the long-term cardiovascular and renal complications of pre-diabetes and intermediate hyperglycemia and how to prevent them, as well as understand the potential applications of new pre-diabetic and intermediate hyperglycemia treatments to prevent diabetes development. This podcast is part of the continuing medical education program entitled Prediabetes/Intermediate Hyperglycemia and Diabetes, Diagnosis, Guidelines and Management for 2025, targeting clinicians involved in endocrinology, particularly diabetes, prediabetes, intermediate hyperglycemia, obesity management, and general practice. Some content may be of interest to vascular specialists and cardiologists.
Hello, I'm Maria Inês Schmidt, a professor at the School of Medicine at the Universidade Federal do Rio Grande do Sul in Brazil. I will present on the topic cardiovascular and renal disease in prediabetes, intermediate hyperglycemia, and prevention of long-term complications. This is an exciting topic with very recent news, which help to clarify long-standing questions. I will highlight these new findings and point to some of the remaining gaps. I will focus only on type 2 diabetes, and thus I will not address issues related to adult-onset type 1 diabetes.
What are the long-term cardiovascular and renal complications of prediabetes/intermediate hyperglycemia?
Well, let me start by saying that prediabetes intermediate hyperglycemia is by no means a benign condition, nor an innocent risk factor. It is defined by glycemic parameters used to diagnose diabetes. Thus, prediabetes intermediate hyperglycemia is usually seen as a condition preceding type 2 diabetes and the specific microvascular complications. However, the multiple chronic complications that are associated with prediabetes go much beyond those related to hyperglycemia and include cardiovascular diseases, renal diseases, and even cancer and dementia. Among the cardiovascular complications, prediabetes intermediate hyperglycemia is associated with increased risk of cardiovascular mortality and vascular or myocardial heart endpoints such as cardiac events, stroke, heart failure, and atrial fibrillation. Among the renal complications, prediabetes intermediate hyperglycemia is associated with incidence of chronic kidney disease, usually in association with various metabolic abnormalities that are traditionally related to diabetes.
Compared with normoglycemia, is there always an increased risk of cardiovascular disease in those individuals with prediabetes/intermediate hyperglycemia?
Well, not really. Prediabetes intermediate hyperglycemia is very heterogeneous. It comprises groups of people that have different phenotypes and have distinct types of progression to diabetes and other complications. Each type, group, or stage is characterized by a set of features defined by a specific pathophysiology, risk of diabetes, and risk of chronic complications. Among the different types of prediabetes that are defined prediabetes, we can characterize them by glycemic tests, like an oral glucose tolerance test, a fasting plasma glucose, or an HbA1c. And these tests characterize basic three types of prediabetes intermediate hyperglycemia. IGT, which is impaired glucose tolerance, impaired fasting glucose, and elevated HbA1c. As you probably know, IGT is consensually defined by an abnormal plasma glucose 2 hours after the ingestion of a solution containing 75 grams of glucose, the values being 7.8 to 11.0 millimoles per liter or 140 to 199 milligrams per deciliter. IGT predicts greater risk of chronic complications when compared to normal glycemia. So this is the first issue that we need to consider in the heterogeneity of risk. The thresholds that define impaired fasting glucose and elevated HbA1c differ between health organizations, the most frequently adopted clinically being those defined by the ADA. When compared to normal glycemia, IFG and elevated HbA1c defined by the World Health Organization and by the International Expert Committee on HbA1c, they predict a greater risk of chronic complications than those defined by the ADA. We'll understand a little bit of this later on. When compared to normal glycemia, IFG and elevated HbA1c defined by the World Health Organization and by the International Expert Committee predict increased risk. For example, a systematic review by Schlesinger et al. In 2022 shows relative risks that vary between 1.06 to 1.39 for various outcomes, including cardiovascular outcomes and renal outcomes, generally greater for IGT and frequently not significantly so for HbA1c. These increased risks are not very large, as you may see, because they are estimated from very heterogeneous groups of people. And the greater effect that we are seeing for IGT probably reflects that it captures more directly beta cell failure. The greater effect for WHO thresholds probably results from the more stringent thresholds that they use and thus reflecting a higher risk. However, the heterogeneity of prediabetes intermediate hyperglycemia goes beyond these glycemic parameters and encompasses different type 2 diabetes pathophysiologies and different metabolic phenotypes. Now, if IGT is usually the best type of prediabetes to predict chronic complications and even diabetes, why the oral glucose tolerance test is not done more frequently in clinical practice? Studies conducted over the last decade have shown that the 1 hour value during a 75 oral glucose tolerance test is even more predictive of diabetes and of chronic complication than the 2 hour. And of course, it may be more convenient by reducing the time that need to be spent in the lab and the resources needed to perform the test. These studies have led the IDF to recommend in 2024 the use of 1 hour glucose tolerance test in the prevention of type 2 diabetes. And their cut points they recommended is 7.8 to 11 millimoles per liter or 140 to 199 milligrams per deciliter to define intermediate hyperglycemia, and higher cut points, 155 to 209 milligrams per deciliter to define diabetes, or in millimoles per liter, 8.6 to 11.6. So how do we characterize the heterogeneity of prediabetes intermediate hyperglycemia that go beyond glycemic parameters and encompass different types of type 2 pathophysiologies and different metabolic phenotypes, each with a distinct picture of increased risk of chronic complications? The last July, there are some interesting papers published that elucidate this question. The first was in the Diabetes Prevention Program, which is a study that was conducted in the US to prevent diabetes using lifestyle intervention and metformin. And the long-term follow-up allow us to evaluate these findings. So using a clinical phenotype based on 12 characteristics like fasting glucose, fasting insulin, glycated hemoglobin, HDL, LDL, total cholesterol, systolic blood pressure, diastolic blood pressure, estimated glomerular filtration rate, microalbuminuria, body mass index, and waist circumference, they were able to identify 4 groups of risks. The first and the second having lower risk, and the third and the fourth having higher risk. Cluster 3 has a very high risk of diabetes and microvascular complications, and cluster 4, low risk of diabetes and high risk of estimated MACE and renal dysfunction. In the same month, another study was published using a different way of assessing this cluster developed by Robert Wagner's group, and they identified 6 clusters, 3 of low risk and 3 of high risk. And the 3 in high risk had different factors of risk, some of them more associated with diabetes and some more associated with cardiovascular disease and kidney disease.
How does metformin reduce the incidence of cardiovascular disease?
Well, primarily being an anti-hyperglycemic agent, metformin also has pleiotropic effects on different systems and organs and processes. Its major effect is activating AMPK in the cells and reducing glucose output from the liver. But it also decreases advanced glycation end products and reactive oxygen species production in the endothelium, apart from regulating the glucose and lipid metabolism in the cardiomyocytes, thus potentially minimizing the cardiovascular risks. Perhaps one data that we should look into is the DPP that I mentioned previously. The DPP follow-up has reanalyzed their data, considering 4 different approaches to deal with the reassignment of groups that were receiving metformin. Number 1, the placebo who developed diabetes ended up using metformin. And some who were using metformin ended up stopping the metformin use because of the presence of side effects. So they had to do some reanalysis to take this into account, and they used 4 different assessments of bias to do this assessment. And what did they conclude with this? And this was also published very recently. They found that indeed metformin reduced the incidence of diabetes compared to the placebo group, that they may have some effect in reducing the incidence of cancer, but it has no effect in reducing other complications. I believe the next step that DPP will do, and we'll have to wait for this, is to reanalyze these outcomes based on the 4 clusters that I just mentioned to you a few minutes ago. And it's possible for us that cluster 3 will show a better effect on diabetes prevention and cluster 4 on CVD renal prevention. We just need to wait a bit more to know this.
What take-home messages do we have at the end of this podcast?
Well, I think first we really need to understand and act in accordance to this, that prediabetes is not a benign condition, that it predicts different risks, which are better characterized by post-load glycemic values, either 1 hour or 2 hour plasma glucose during an oral glucose tolerance test, that metabolic phenotyping can define specific groups requiring more specific attention, given their increased risk of either diabetes or of chronic complications, including CVD and chronic kidney diseases. And then for these specific groups, perhaps use a very intensive treatment, always starting with lifestyle intervention and, when needed, medications, including metformin or other drugs that are being released. Thank you for your attention.
Thank you for listening to this Medea podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.